So what we're going to do is we're going to do a T12 kyphoplasty, and then we're going to do an L1 vertebroplasty. This is Dr. Zane Timchak, lumbar and thoracic spine extraordinaire. Right? So what we have on the screen right now, if you guys can see that, is that we've sort of lined it up for a T12 kyphoplasty. And where the thoracic spine is different, as you all know, the anatomy is different in the thoracic spine compared to the lumbar spine, where the thoracic spine, and it gets more accentuated as you go cranially, is actually longer and narrower rather than wider compared to the lumbar spine. So typically, when we do kyphoplasties, vertebroplasties, and or even percutaneous guide wires, typically in the lumbar spine, what we'll do is when we take a look at the pedicular shadows, I don't know if you guys can see this or not, but right over here, typically on a lumbar spine, yep. So this is the lumbar spine. Typically, on the right, we'll aim towards being at the 3 o'clock position, and on the left, we'll aim towards being at the 9 o'clock position. And then we'll actually orient all of our instruments and our jam sheeties, guide wires, even pedicle screws to parallel the superior end plate. The thoracic spine is a little bit different because, as you know, the thoracic pedicles end up going more from cranial to caudal, and it's much more in the sagittal plane. So most of the thoracic pedicles are more in the mid-sagittal plane, and as you go from upper lumbar to lower lumbar, it goes from more sagittal to more of a coronal orientation. So what we're going to do in the thoracic spine is that we're going to try to sort of go a little bit more in the 2 o'clock position on the right and more on the 10 o'clock position on the left, and aim from cranial to caudal. And we're going to try to actually sort of converge together. And so if you take a look at this, again, the quadrant, I'm going to try to stay sort of in my half, and then Zane's going to try to stay within his half. And then on the sagittal view, we're going to try to be sort of in the center, but slightly a little bit anterior, okay? So we're going to start by sort of putting our jam sheeties here, and go ahead and picture that. And can you straighten that up and down? And then go ahead and picture that. Do I have a knife? So I like to make transverse incisions just through the skin. It's kind of dull. Here you go. And then we're going to need cokers ×2. And what we're trying to envision is some of the C-arms actually have a laser. So the laser goes from the center to center. And so what we tried to do is try to match that angulation. And what we're going to do is I'm going to try to envision this coaxis of this. And then we're going to try to get to a bony. Picture that. Okay, so if you take a look at that picture right there, I'm too medial. Zane, you're looking pretty good. Maybe be a little bit more cranial. Go ahead and picture that. Maybe just go a little bit more cranial and a little bit more
lateral.
And more lateral, yep. Picture that. Okay. And then can you pull yours back just a little bit to see where your starting point might be? Picture that. Okay. So at least I like the starting point. So I'm going to start this just a little bit so I'm anchored to the bone itself. And maybe you'll do the same. Let's see where we're at. Picture that. Okay. That looks pretty good. I would probably start going a little bit more medial. And then I'm going to actually go a little bit more caudal and a little less medial. Picture that. Picture. There you go. That's kind of the angle that I want. I'm in the pedicle now, picture. And I'm sort of headed toward that mid portion of that picture. And that now I just hit the medial border of the pedicle. So as long as on the lateral view, I'm anterior to the posterior vertebral line, it's going to be looking pretty good. And I would mirror what I did right there, Zane.
Shot.
And go more medial. So maybe this way, yep.
Shot there.
Yep, that looks good. And then go a little bit more cranial, slightly more cranial.
Shot.
That looks good. I would go a little bit more now, yep.
Shot there.
That looks great. Okay, and then go to a lateral. So we'll see where we're at on this lateral view now. Okay, and then can you change your wag just a little bit this way? Yep, and then come down south, a little bit more. Come down south, and go ahead and picture that. That looks great. Okay, so that's a much more true lateral view. Picture that again. And then we're gonna go in probably about another centimeter or so, both of us. Picture that. Good. And then we're going to take out the inner trochar. Picture that. So that's me. And you need to go in a little bit deeper. And then I would head caudally also. Picture. That looks great. So just go in just a little bit more. Yeah. Okay. Now we're going to take this drill to create a little pathway into the bone itself. And there are little marks here letting us know how many centimeters deep we are. So when I insert this, I know that I'm actually at the tip right there. So I'm going to go in probably about another centimeter or two. So I'm about a centimeter deep right there. Picture that. There we go. And I'm going to try to go maybe like 2 centimeters. Create a little pathway. Picture. Maybe even just a little bit deeper. Picture. And that's about where I want to be. You know, so we're in the anterior zones. So I want you to go the same amount. And I can take mine out so you can take a look at your drill.
Let's see a shot there. X-ray.
Good. That looks great. And so why don't we do one thing? I'll take my drill back, and then we're going to go to an AP
X-ray.
to see where we're at. So, keep it in there. Let's see where we're at on an AP view. You know what I'm saying? Picture that. Good. And then go just straight to 90 degrees AP. So we know we're anterior enough now. So we're going to want to get a better sense of where we're at with respect to the medial lateral, because we want to be converging, but we don't want to be so close that our balloons are going to be touching each other. You know, if it is, it's okay. But that looks great. They're converging together. So I am in my part of my zone. Zane is in his part of his zone. We're going to get a pretty good fill when we take a look at that. So go ahead and save that and transfer that over. We see that nice going from cranial to caudal on the thoracic view. So go back to lateral again. So there are a couple things here. There's sort of a new technique that we're going to show you here, and this is relatively new actually. So instead of going straight to the inflatable balloon tamp, we're actually going to show you a demonstration over here of a new radiofrequency probe that can help with, is the video on here yet? Is there a way to actually get the video here? So essentially what this does is if you have a tumor burden within the vertebral body, it allows you to use the RF in order to actually heat the area. So meaning that you can actually use heat to actually kill some of the tumor cells actually. And so what this is demonstrating is that, let's just say, for instance, we had the trochar in already. So what we do right before the balloon step is that we would actually introduce this RF probe. And then over time, and it varies depending on the size of the vertebral body, and the lumbar spine, because of the fact that the vertebral bodies are larger, we would go on average maybe about 15 minutes. And in the thoracic spine, anywhere from like 6 maybe to 15 minutes, depending on the size of the vertebral body. But you can see this over time. We've had this cooking. This is actually a piece of chicken. Literally is a piece of chicken. So we've had this cooking now for the past 10 minutes or so. And so you can already see this area over here that has created this area, this zone of heat from the RF probe. And it's already, you can envision that if you actually had tumor cells here, that would help kill off some of those cells actually, right? And this has been shown to actually help with tumor pain as well. So once you've actually done this RF probe, then you can jump straight then to the balloon, and then finally to the cement augmentation here. So we'll go back here. We'll assume that we did the full 15 minutes. We'll take out our drills, and then we're going to take our inflatable balloon tamps. And so what this is no different from a balloon tamp that you'd find for angioplasties. So essentially what it is, it's hooked up to this device, which gives us both volume in cc's as well as pressure in psi's. And within the balloon itself, there's actually two radiographic markers, one in the distal part of it, of the balloon, and one in the proximal part of the balloon. So we can really guide it and get it to the point where we want to have the greatest amount of bone tamping effect. And as I mentioned previously, we want it to be in the anterior aspect of it. I'll put mine in first. So there's a little marker here showing me that I'm actually at the base of it. So I have not yet gone in. So if we take a picture, you can see that you're not going to really see anything. But as I start slowly advancing this, picture that. You can see where that marker is. I'm going to try to go back to where I was previously. Picture that, which is right around there. And I think that's a pretty good place to be right there. Just slightly anterior to central. So Zane's going to actually put his sort of in the same place as well. If it's not advancing, we could always recannulate. That looks pretty good.
Pretty good.
And so now what we're going to do is we're going to both sequentially, we're going to start twisting this, and we can see how much volume we're actually delivering to the vertebral body through the balloons. So I'm at 2 cc's now, so let's take a look at that, picture that. You can already see that it's starting to tamp that vertebral body up. This cadaver does actually have a real vertebral compression fracture. It's a mild wedge-shaped deformity. And I'm looking at right now the PSI is at 191. This can go up to 700 PSI, so it's very powerful. I can also sort of take mine out and see where Zane's is at. Picture that. Okay, so your fill's looking pretty good too. So we're going to get to this point where we feel like we have a sufficient amount of volume placed, and then we're going to take a look at the AP view. So how many cc's are you at, Zane?
I'm at 2.
Yeah, I'm at 2. Maybe, let's see if we could go to 3 and where we're at. Okay, I'm at 3 there, and it's at 250 right now, PSI.
I'm at 4, just over 400.
Okay, picture that. Okay. Let's see if we can go up to 5. This is a cadaver, right? And then we'll stop at 5. I'm at 350 there. Picture that. That looks great. So save that and go to an AP. And presumably, if this was an acute fracture, this would help to sort of tamp those end plates, as long as the end plates were intact, sort of reduce the kyphotic deformity there. Go ahead and picture that. So it looks like you can actually go a little bit more, Zane, right?
Yeah. Let's see a shot there.
How much volume are you at right now?
That's at 5.
5?
Yeah.
That looks pretty good.
Shot there.
That looks great. Whoa. So we pushed the boundaries just a little bit. That's actually interesting though, right? So why don't you save that, or picture one more time? Interesting. And then go to a lateral. So, yeah, we'll suck it out with that. Okay. So that must mean that, did the balloon?
Well, you're rated for 5.
We pushed the boundaries. We're rated for 5 there, actually, you know? So we have like radio opaque dye actually going, but let's see where it's at. Let's see where it went. This is really interesting. Interesting.
All
So
along
this
there.
actually follows
basic
exactly what
vertebral.
my talk was just saying. Do you guys see that? So what ended up happening is that balloon extravasated, and it went through the path of least resistance through the basivertebral venous system to the epidural plexus. That's a cool picture. So why don't you undo that? And we won't need to replace this. We'll go straight to cement. I want to see where the cement actually goes, So we're both going to sort of take our pressure off the balloon there. And let's see where we're at when we take these out.
Do that back.
Picture that. My balloon's not. That's mine.
Let it squeeze and pull all the way back. Okay, and then just let go. Let go. I'll take a picture.
Picture? It just takes a little while, right? Picture? There we go. Okay, there you go.
Maybe one more time.
One more.
Are you just sucking it out? Yeah. Picture that? Okay. So you can see the cavities that we've created. Normally you wouldn't see this picture, but because of the fact that there's actually some dye there, it gives us a shadow of where we were. So now we're gonna actually start putting in our cement, and picture that. And this will allow us to actually get to the depth that we want, picture. And so we're anterior to here, picture. So we'll start here, and each of these marks represents 0.5 cc's. So both Zane and I are going to start sort of slowly filling at 0.5. And this is kind of doughy cement. It tends to cure a little less. And so when we're both at 0.5, we're going to picture that. There we go. There's our cement fill already. And we're going to go another 0.5 cc's. Picture. We're starting to get really good fill there. So we're going to sort of go another 0.5. And picture that. Okay. So you'll recall that we were able to tamp at least up to 5 cc's. So in theory, we should be able to put in at least 2, maybe if not 3 of these. So picture that. And so maybe we'll back it up just a little bit, Zane.
Okay.
And picture that. A little bit deeper, maybe about another centimeter. Picture. Yeah, let's start filling there. Okay, picture that. Yep, we're starting to get good fill. Picture. That looks great. Picture. And we're going slow because remember, the rate is important to make sure that it doesn't extravasate. Picture that. And then we'll just go one more.
Okay.
Because this should be 4.5, right? So picture that. And we'll go, picture that. And picture that. Picture that. So let's try to get to that middle to posterior zone, Mm-hmm. Try to get a little bit of fill in that back part of it. I can tell it's starting to get harder, right?
Yeah, it is.
It's starting to cure. Picture that. Look at that fill. That looks great. So once we do this, it should be 4.5 cc's. Picture that. And so there's no evidence, even though the dye previously went through the basivertebral venous system. Picture. Thus far, there's no evidence that there's actually, oh, there's a little bit right there, actually. Do you see that? So there's a little bit that actually went through that. It probably went through that previous. Okay, picture that. So we'll let this harden. There you go, right there. But again, that was because we sort of overinflated the balloon, so I'll take responsibility for that. So we can let this harden. Typically, you kind of keep it in there. And what we do is, once it hardens, then we can take the entire thing out. Because otherwise, sometimes you can get a little track of cement within the pedicle itself, which isn't horrible, but it just kind of looks bad on X-ray. Go ahead, picture that. Great. Okay, and then why don't you go to an AP, transfer that over? Okay. So as we wait for this to harden, do we have another set to work on the vertebroplasty? Okay. So we'll go down to L1, so come down just south about another inch or so. And then whenever we're ready, we'll get the trochars. Yeah. But that fill on that AP is really good. I like that. That fill looks really good. You know, I filled my half, you filled your half. On the lateral view, we're a little bit more anterior, just slightly more anterior.
Yeah.
It's got good filling characteristics. Do we need to take these out in order to?
Yeah, we've got.
Okay, let's go for them then. Okay, now we're gonna go for the L1. This is how you do the lumbar, and we'll do a vertebroplasty at this level. Go and picture that. Come down south about another inch or so. That's good, picture that. And so now we're gonna aim towards the 3 o'clock position. You're perfect, absolutely perfect, so you can make an incision right there. And I'm gonna go a little bit more medial, picture that.
Skin knife. Is this
Yep.
a new blade? Okay, great.
Yep, that's good. And this is a funny thing, like with these, you don't even need a 10 blade, you could use like a 15 blade, because it really is just like truly percutaneous. And then we'll take the cokers.
Thanks.
And then we're gonna sort of go parallel. Picture that. Okay, I just need to go a little bit lateral. You need to go cranial and just cranial, actually. Picture that. And picture. Yours is actually looking pretty good. Let me see, picture that. This is actually a good starting point too. So why don't we both start it, mallets please, and then aim caudal a little bit.
Yeah.
Yep, I slid off, so you. Picture.
To aim medial.
I think you're sliding off a little bit, huh?
Yeah.
So you might want to picture that. You might want to take a slightly medial, more medial.
X-ray.
Picture.
X-ray. High. X-ray.
That looks pretty good. I think we could both go here. Just need to get it in and then just aim caudally just a little bit once it's in.
Shot.
Okay, good. Now just aim slightly caudal from there, and I think we're gonna look pretty good.
Shot.
That looks great. Save that and transfer that over.
Have to go down.
So we're starting to converge together. We'll see where we're at on the lateral view. That looks great. So maybe about another centimeter.
Mm-hmm.
And this time we're a little bit more parallel, which is fine. Let's just assume that we wanted to guide it toward the superior end plate, where a lot of these fractures, as I'm sure you all know, occur. So now we're going to take this out, and we're going to drill.
I got mine here.
You do? Okay, great. So we'll kind of drill to that anterior zones 1 and 2. Picture that. Great. Maybe at about another centimeter. Right there. Picture. That looks great. Okay, and then we'll take these out. And then we're going to go straight to cement.
It's a little thick.
This is a vertebroplasty. This is from the previous one?
Yeah, this is from the previous.
Ooh, it might be thick.
Yeah,
Picture.
it might be a little thick.
Picture. So this is going to be vertebroplasty. Picture. So that we have not created
Can I see a shot?
a pocket. So the filling characteristics of this is going to be very different. Picture. There we go. Okay, and I've got 1.5 cc's in mind. Picture that. Okay. Take the next one. And then what for vertebroplasty is kind of the same thing. Now I'm just going to go right behind where I was previously. Picture. Right, probably right there, in that sort of mid portion now.
Can I see a shot there?
Yep. Maybe a little bit deeper.
Shot?
Yep. So we're filling, we can sort of back it out slightly. Picture. Yeah, there we go, right there. We want to fill that zone. And in reality, we can sort of direct this based on where the fracture is, you know? So for these vertebral compression fractures, as you know, it's a wedge-shaped vertebra that's fractured more anteriorly. Picture there. That looks great. Look for one more.
This is going to be a little wet.
It is? Okay.
It's a new batch.
Okay, got it.
Okay.
So this is less doughy, more viscous. Picture. 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 Okay, so maybe let's try to fill this posterior aspect. Picture. There we go. That's great. Picture. Picture that. Picture. That looks great. And we may want to just picture. Okay, save that and then go to an AP. And you can see that there's a definite difference here. This is much more sort of oval shaped and very, very consistent with the balloon that we actually use as a tamp. Here, it's just essentially going, through the trabecular bone, just following the path of least resistance. And that looks great too. So that's, interestingly, I don't know if you guys can see this or not, but there's a little bit of extravasation laterally here, right?
Yeah.
So even with that, and remember what I said about if it touches the cortex, there's a higher incidence of it extravasating. That's what happened here. So on my side, it touched the cortex and it extravasated through one of the external veins there. But that's pretty much it. Any points, Zane?
No points, but I was wondering, when do you choose between vertebroplasty versus kyphoplasty, some of the indications?
I think that if it's tumor, typically I think most people err towards doing more vertebroplasty because you want to try to maintain sort of the integrity, and you don't want to be embolizing. Like the thought is, you don't want to be embolizing tumor
Right.
into the venous system, right?
Right.
Whereas in a vertebral compression fracture, you want to try to be able to reduce the fractures as much as you possibly can. In general, I probably err towards doing more kyphoplasties rather than vertebroplasties, but it sort of depends on what you're trying to accomplish, you know? So I think having something like this makes a lot of sense to do the RF probe on the tumor itself. And then once you do that, probably just do a vertebroplasty, just to sort of maintain. But if there's tumor associated with some vertebral body collapse, then it probably makes sense to use the balloon to try to tamp it up just a little bit, prior to placement of the cement. Any questions or comments from the audience?
Dan, any question?
Yeah, I have a question. Dan Schuba here. This is straight on, perfectly orthogonal, right in the center. Do you ever angle these needles differently and try to shoot in one corner or across some fracture plane, or do you just try to get it in the middle in the zone and use the zone theory to avoid extravasation that's safer and better, or do you actually try to be directed?
It depends on whether or not it's just a pure osteoporotic VCF versus tumor. If I know the location of the tumor, I will try to put all of my instruments as close to tumor burden as possible. And you can play around with the starting point of your trochar will dictate how it fits and how it's able to sort of maneuver within the pedicle. So the way that you can think about that is, you know, the pedicle is essentially, it's kind of like a nuclear reactor shape, right? And so there's an isthmus right in the center. So if you think about it, if you stack up multiple cylinders, in the isthmus, it actually gets very narrow. On the outside, it's almost like having two trumpets sort of like on opposite ends of each other. So essentially, if you want to try to get to, it might be better if I try to illustrate it here. If I know that the tumor, say for instance, is actually in this quadrant here, right? Sort of on the left lower quadrant, then probably the best approach would be for me to actually start here and then aim down this way, right? And then on this side, I could start here and then aim down this way. And then that's where I would try to put the majority of my cement there, always looking for fill, you know? But with respect to, you know, VCFs, they're pretty symmetric most of the time. So if they're symmetric, then this is the fill pattern that you want, you know? This is ideal, but you can also direct it. So meaning that on this view, you know, most of our cement here is actually in the upper half. And so if this was a vertebral compression fracture that started here, you know, assuming that the superior end plate was still intact, this would be a perfect fill for that. This would be good in general. This is like this kind of the filling pattern I want in general for VCFs. Fill more anteriorly and then sort of come back here more posteriorly here. So this is a good filling pattern in general for most VCFs. Did that answer the question?
Absolutely.
Just a few comments. So if you look at how this procedure was done, I think the two critical aspects of this procedure is one, placement of the needle, and two, injecting the cement. And if there's one thing that I would emphasize about introducing the needle through the pedicle, is you don't want to put the needle through the canal, right? So your friend is the medial wall of that pedicle. The medial wall of that pedicle. So as you are introducing that needle and you're advancing that needle, always make sure that the tip of the needle does not traverse the medial wall of that pedicle until you are in the vertebral body. Once you're in the vertebral body, you can medialize the needle, you can do whatever you want, but you cannot advance the needle and keep advancing the needle once you reach that medial wall. You have to be able to, you have to get to the point where you reach the medial wall with the needle and you're already in the vertebral body. If you get to a point where you have advanced the needle and you reach the medial wall and you're only halfway down the pedicle, you're still in the canal territory, you have to reposition the screw because there are incidences of injuring the nerve roots or even the cord by not paying attention to that medial wall. So the way I approach this is I actually don't place the needles in a pure AP view. I put them in a more of an oblique view that allows me to have a little bit better safety margin of advancing along the pedicle. But either way you do it, make sure that when you advance the needle, when you reach that medial wall, you check a lateral. And if you're not in the vertebral body at that point, you can't keep advancing that needle because you're now in the danger zone. So you can advance that needle up to that medial wall. Once you're in the vertebral body, then you can keep advancing that needle.
That's an excellent point.
Yeah, I mean, that is really the critical part. I think the critical part is really placing the needle. That is the difficult part. The cement and everything else, you get used to it. But don't advance the needle further than the medial wall unless you are already in the vertebral body. Yeah.
Jeff, you're a master. I can never get my kyphoplasty and vertebroplasty to look like the x-rays you just showed.
Yeah.
Thank you. I have really good help here to keep me in check.
Yeah, right.
One question for you, Jeff. So if you're doing this and you all of a sudden see cement going where it shouldn't be, like posteriorly, can you give us some advice on what to do at that point?
I mean, in all honesty, what happened here is actually a good learning point, right? I wouldn't let it get to that point because I'm much more, anal retentive during the case. And so if I see that there's even just a little hint of dye going into the posterior canal, I stop everything, you know? So what we should have done, what we would have done in a real patient is that we would have advanced that trochar more anteriorly and then continued to fill there, and just to make sure that we get enough images to ensure that it's not continuing to go into the canal. To tell you quite honestly, like that fill pattern right there where there was just a little bit sort of, it's interesting because it follows the plexus, you know, the venous plexus. And it probably what's happening is we got a little bit of cement in the venous plexus, but as long as you don't have like a large, space occupying lesion within the spinal canal, it typically is not that big of a deal, you know? But again, in a real case, I would have, if I even saw a little flash of dye going into that posterior plexus, I would just stop right there and then advance it more anteriorly, and then continue, but being very cautious about making sure we fill that very deliberately.
So cement migration into the canal, you have to watch for it. And sometimes it's behind the needle. You see how when they were injecting the cement, you kind of couldn't see it, and boom, the next thing you know, it's right there.
Yep.
Sometimes you can see that the cements kind of go behind it. You have to kind of be aware of it. Look behind the needle and see if the cement is there. Most of the time, if you notice it, even if there is a little bit cement in the canal, the patients have no symptoms related to it. How many times you see patients who have a little bit cement in the canal, no symptoms? But what do you do? What do you do when you have a patient that wake up with a deficit? And it gets me to the point that when you do these procedures, make sure you examine the patient after the procedure, especially when you're worried about cement migration into the canal. You have to do it. You have to examine the patient, make sure there's no issues. What do you do when you have cement migration into the canal and the patient wake up with a deficit?
Yeah, so luckily it's never happened to me, but I've had patients referred to me, and I'm sure many of you have as well. So the first thing I would do if it happened to me, the patient ended up, with new pain or weakness or paresthesias postoperatively, I would send that patient immediately to a CT scan. Get a CT scan, confirm the diagnosis. If there's evidence that there's actually cement extravasated in the canal, I would then take the patient back in for decompression.
So what do you mean by decompression?
I would do a laminotomy, typically, and then I would explore that area. So, I've taken out cement before, so it's like having a central disc herniation, essentially. But the zone is a little bit different because it's not at the disc space level; it's actually at the vertebral body level. So typically, what you can do, because in reality, the PLL is still intact. So what you can do is you can do a laminotomy and then retract the neural elements over, and then you can actually sort of make an incision over the PLL and extract the cement out.
Yeah, so most of the time the cement is behind the PLL,
Yep.
and so it doesn't cause, the likelihood of symptoms is very low. But what happens a lot with this situation, when patients come in, let's say with dense neurological deficit, and you have to go in there and take the cement out, is you're already dealing with patients who have an issue, right? They're either osteoporotic, very osteoporotic, or this is a tumor case on a patient who probably was not a candidate for a vertebrectomy, and that's why you're doing the vertebroplasty. So there may be an issue where now you're doing a laminectomy, you have cement in the canal, you may take the faceta, whatever it is that you do, you may have to now do instrumentation after that. And so my point to all this is that when you do this procedure, that's part of the risk of the procedure, right? You want to mention the fact that there's always a chance of cement migration into the canal that may necessitate emergent surgery to take that cement out of there or decompress the spinal canal. It has to be part of the consent. Yeah.
Are the deficits due to mass effect?
Yeah.
Due to toxicity?
Yeah, typically it's due to mass effect if it's that quick.